Let's confirm. The outline you're going to look at is how the country has made progress in the to 1990, and then the key program updates and how we are doing during this COVID-19 in terms of the priorities and the lessons we have learned and which are the next steps. As most of you are aware, we early this year, around February, we were able to release the CALHIV data in terms of the cascade of how the country is doing in terms of the first 90, second 90, and that 90. And by age 15 to 64 years and gender, that's how we were performing, 79.5%. And as well as you can see, it is disaggregated to in terms of the female and male. And you can see females, we were doing a bit better, but male, we were a bit lower in terms of 22.6. And this one is at CALHIV by at 2018. And then we were able to link up around 96% of our clients to treatment. And then out of the 96% that we were able to link them to treatment, 90.6% were able to attain the viral suppression. Definitely we note that out of these, we had a gap in attaining the first 90, and as well as particularly in men, and the various DST models, differentiated service delivery models implemented for adults living with HIV, were able to help us to be able to retain them and as well attain the viral suppression. In the ages between 0 to 14, you can see that is where we have been having a big gap. But that one is up to 2018, but we are doing, we are a bit well now, but still have some work to do. Noting according to what is in the presentation there, that the first 90 and the third 90, we still have the gaps. But we are putting measures as the Ministry of Health, and we are grateful definitely to the Minister of Health leadership, from the Cabinet Secretary to the Principal Secretary, as well as to the DG, who have ensured that several measures that we are putting in place, and as well thanking the county government and the various donors and implementing partners, so as we can be able to attain the first 90. And especially addressing the third 90, because now we have different treatments which have been able to help us to be able to put clients, children who are living with HIV in optimized regimens. Comparing December 2019 and June 2020, you can see how we were performing. We had a bit of dip. I'll be showing in other slides. We have April and March, we had a bit of dip, but we are stabilizing now, even though we are not there. And you can note that we did not really go off mark in terms of the second 90 and the third 90. We are a bit stabilized in terms of children cascade. And I think you have to note that whatever I presented before was on, was on uptake, was on coverage, and whatever I'm presenting is on uptake. So in terms of uptake, you can see we're at 81.7%, that is at December 2019, and at June 2020, at 83.4%. Why? Because in around September, October last year, we were able to release 2 guidelines, optimizing our children, especially the ones who are on nevirapine-based regimens. And in April this year, we were able to as well phase out children who are on nevirapine-based. That is why now at least we are from 68% to around 83.4% as at June 2020. In adolescent, and as well, we know one of the populations we are having a gap in is adolescents and young persons. For example, as at 2019, we noted that whole year, the new infections, 42% of the new infections were from the adolescents and young persons. And you can see the first 90, at December 2019, we were having a very big gap. But at June 2020, it's because we are at 6.1. Because of different measures, especially in terms of messaging, advocacy, communicating to them, but as well as utilizing like HIV self-test kits, and as well having interventions, moving the services near to them. In overall cascade for the 2 groups, that's adolescents, the adults, and as well as the children, we were able to, that's how we are performing through. But at least the previous 2 slides disaggregated that. What has worked well in the first 90, the second 90, that 90 is, for example, integration of HIV testing within several service delivery points, as well as provider-initiated treatment testing and counseling. assisted partner notification, and as well as HIV, utilization of HIV self-test kits. In the terms of the second 90, the test and treat guidelines, which were released some time back, and as well escorts on newly initiated for linkage and guidance on optimized regimens. And that 90 mostly is on viral suppression, implementation of various differentiated service delivery models, adaptation of optimal ART regimens, especially moving from TLE to TLD, and treatment literacy, and as well as utilization of peer support to vulnerable clients. So we, as a Ministry of Health, we've been looking into 4 specific indicators. Number of people living with HIV, that is the newly identified, number of persons with HIV that have been started on ART, that's the second 90, and thirdly, number of people living with HIV that are currently living with HIV but have suppressed. So, and the proportion of HIV positive pregnant, or the ones who are attending postnatal care, women either on HAART, either in ANC or PNC. So that's a trend, and as you can see, in HIV identification and performance between January to July. January, we were doing okay, February as well. We had a bit of dip, comparison between 2019 and 2020. And then April, when the first case was diagnosed in March, almost end of March, April and May, you can note that we really did not do well in identifying the clients who are HIV positive, but at least we are stabilizing now from June to July, as you can note from the graph presented. In terms of trend of enrollment on ART for HIV patients, that's in comparison between 2018 to 2020, you can see the dip how it is, but now from May, June, July there, we're a bit stabilizing to how we were performed in 2019 and 2018. Trends on newly enrolled patients on ART between the 3 years, January to July. You can note we identified, yes, in March and April, there in May, but the clients who identified, we had a bit of an issue within our facilities that they were not linked to care. Remember that at the time we had lockdowns, we had curfews that really limited our clients. After the first session of the counseling, that to be linked to care, even though we have the test and treat guidelines. However, in June and July, we are really working very closely with the counties to ensure that those clients who are identified as HIV positive, that they are put on treatment, so as well they can be able to virally suppress, and knowing very well that COVID-19 is as well affecting clients who have comorbidities. So that's something that we are really working closely with the partners, but as well requesting our stakeholders to ensure that we link our clients so as we can protect them from acquiring COVID-19. This is a trend of people living with HIV accessing ART to 2018 to 2020. And you can note at least we have stabilized. We are really not doing that bad in comparison between 2018 and 2020. Comparison of people living with HIV accessing ART in terms of numbers. You can see we are doing well. 2020 and 2019, we are increasing in terms of numbers. For example, if you are to compare the month of June, we had around 75,000 accessing ART in 2018. 2019, we had 113, and 2020, 119. I think this is a time I want to highlight what we did in around March this year when we had the first case. We released a guidance, and which one of the areas we did is that we requested the counties to submit their stocks that they have within their facilities. And as well, during that time, normally we usually issue them with only 3 months of stock, but this time we requested them to issue them with 4 months of stock. So as all clients, despite their viral status and the age, that we issue them with 3 months of stock. That's a 3-month multi-month dispensing. And out of that, so as we can limit them, the clients coming to the facilities and not to be predisposed to acquiring COVID-19. But as well, at least we're able to access the treatment. In comparison of proportion of HIV positive pregnant women on maternal HAART in Kenya between January to July 2018 to 2020, you can see this is very key, especially in preventing mother-to-child transmission of HIV. And at least we were over 90%. Ideally, if you are to be certified as a country that we have attained attained that elimination of mass shared transmission is supposed to be over 95%. And at least in May, we were almost there, but June and July, we can see there's a bit of a dip. But in comparison to the other countries, which we hoped that last year will have already been certified. But we note, especially the COVID-19, that MTCT rate is still an issue for us because it's more than 10%. So in HIV prevention, I'll go now specifically to the specific programmatic areas. HIV testing volumes, they reduced, especially pre-COVID, month to month, we had a bit of dip. Especially in community and facility testing. We had a dip of 28% in facility testing. Community testing decreased by 71%. But ANC attendance and testing, it was not big, it was not so much impacted. But testing volumes in totality, both community and facility, we had a bit of dip between March and April 2020. In linkage as well, and I think that's something that I have highlighted before, but we, in terms of now June, July, and August, September, we are doing well. But we are looking into the data of August, so as we can be able to give the status in terms of August in the month of September, around 20th there. So PrEP as well, it's one of the measures that it is utilized to ensure that we prevent our clients from acquiring HIV. Especially, discordant couples and those ones who are in relationships that are putting them at high risk. We noted that at least we stabilized in April to June the clients who are initiating themselves on PrEP. And as well, in noting for the various populations that we have, for example, female sex workers, you can know that they're utilizing PrEP. It increased. But for the MSMs and the people who inject drugs, still it's a bit low. And we know that we have a gap in terms of PrEP, but we are hoping that the new measures we want to put in when things have stabilized, that we'll be able to ensure that more clients are able to access PrEP. HIV testing among female sex workers as well is stabilizing, despite a reduction in April, but we have high positivity for the female sex workers. And, despite even of the COVID, and, in the month of April and May, we had we had a bit lower, but in June, we have noted a bit of high numbers of positivity, and I mean HIV positive, not COVID. And as well in MSM, we have high, despite a reduction in number tested, we have still high positivity, even though we had that curfew and lockdowns noted in several towns, but still that populations that we are putting in measures to ensure that the positivity, it is reduced because we know the risk that it is posed to them. HIV testing as well as people who inject drugs reduced on the month of March and April, but then you're seeing a bit of pickup in June and as well in August, and we have noted that is a bit of high positivity, even though we have they are utilizing more of HIV self-test kits and not really facility testing. Trends in mother-child transmission rates within Kenya is, in the year 2018, it was 12.4. We were very excited because 2019, we were 10.8. And we were hoping we could go back where we were in terms of 2015 and 2016. Unfortunately, with the COVID, we hope that we will not reverse the gains that we have acquired, even though we are noting increased number of teenage pregnancies, which means that definitely that there was no protection that was used. However, data within the next 2-3 months will be able to tell us exactly where we are. Monthly PMTCT testing seems to be stable, but we have a bit of surge in HIV positivity in June, noting now at least mothers who are pregnant or breastfeeding were a bit comfortable coming to the facilities, to access other services, for example, postnatal services, and as well as deliveries. But you can note that surge that we noted during that time. Initiation of maternal HAART, I think I summarized this one a bit way before. I will not dwell on it much. And as well, coverage of the maternal HAART as well, and infant prophylaxis. In the first guidance that we gave in around 24th March, one of the areas that we insisted is in viral load and EID testing of our clients. And one of the populations that we ensured that we have continuity is that for all pregnant and breastfeeding women, and as well the newly diagnosed HIV patients and early infant diagnosis, they had access to our laboratories to ensure they access those services. So that one at least have been a bit stable, even though we know some of the clients were still worried. And I think as well, communication was an issue to them, noting that the services are still available. We have had high impact of COVID-19 on VMMC, that is voluntary medical male circumcision, through facilities are still trying to catch up in June. Per year, we usually have around 200,000 a target to be able to be circumcised. And we noted that in the month of April and May, there was a bit of dip, but at least in June, we noted a bit of pickup to almost 10,000. And we are hoping that in noting now that schools are not being open, because we usually utilize when children have closed school, that they can be able to access the circumcision. But as well, and this one is mostly limited to the populations or the communities which traditionally or culturally do not really circumcise. But at least in the month of July and August, we have a bit of a pickup. So in summary, we have number of people testing for HIV. It has really reduced considerably, especially in the month of March, end of March and April, but trends are stabilizing. We have noted community and facility testing reduced during that time. And as well, quarterly initiations of PrEP seems to be a bit stable, but specific populations seems to have increased. And as well, monthly PMTCT testing seems to be a bit stable. And as well, integration of SLH and HIV/STI prevention collaboration between DFH and NASCOP has ensured that the services, especially of PMTCT, still continues. These are some of the services. For example, in the March, Ministry of Health was able to acquire at least 6 mobile vans. So as we'll have our clients who every day they access methadone within our clinics in several in the country, that we can utilize MAT vans for them to access that drug. But as well, use of boda for delivery of commodities of clients' place of choice, and as well utilization of team leads, the differentiated the service delivery models of once in community ART groups, where one team leader will come and pick the drugs for the HIV positive clients and be able to distribute it within the communities. And as well, having staggered clinics appointments within the facilities, and as well utilization of Ushauri platform, which is an app that the clients can be communicated to, either messaging they can ask questions, and as well they can be able to communicate to in terms of when to come to the facility and or when to see a healthcare worker if there is need be, and as well utilization of HIV self-test kits. For HIV, for care and treatment, we have been had a concern, and I think I highlighted this in terms of clients who are utilizing ART, but I think more what I want to highlight in this is the transition of clients who are on TLE to TLD. We have had progressive increase of number of clients transition to TLD, and TLD helps, at least in terms of virus suppression, is way better than TLE. But I know the caution and the outside there, the data that we had before and the publications are there that pregnant and breastfeeding women were a bit cautious in utilization of it. But men, yes, they can use it. But as well as a country, we are doing pharmacovigilance. So in case of any side effects that we note with the clients who are using it, then we can be able to note it and take the necessary measures that are needed for us. So men currently on TLE, as you can see, we have had good transition. However, some counties are still lagging behind on transitioning men to TLD. So that's how we are doing in terms of the counties, and we have high number of males on TLE. And right now we have issued the other guidance that we issued as at 24th of August. One of the areas that we have highlighted is to ensure that our clients who are on who are already virally suppressed all males that they can be able to be transitioned to TLE, and we are requesting the counties to have active transition that should be done at least by end of October 2020, and as well as in regarding to children and adolescents who are less than 15 years living with HIV from nevirapine or PI and evavirenz-based regimens to optimal ARV-based regimens based on their weight. And as you can see why we really want them to move TLD, look at the viral suppression rate comparing TLE and TLD. And you can see the men who are on TLE, you know, they are at 96% of viral suppression, and the men who are on TLE are 85%. As well as the females, you can note that the ones who are on TLE, they're at 92%, and the ones who are on TLD around 97%. So we have better suppression rates for clients on DTG versus those on evavirenz-based regimens. 14 counties have achieved 70% or more in transition to TLD by June 2020. And we are really working close and requesting the counties who are really lagging behind to adhere to the guidance given by the Ministry of Health and to ensure that they transition to this optimized regimen. Pediatric dispensing, I think this one have highlighted before in terms of the multi-month dispensing of the 3 months. And we note as well that some clients were being issued as well to 5 or 6 months. And one of the things that I mentioned to the partners is, yes, we know if a client is very suppressed, then there's not really inhibiting them to move to the 6 months or 7 months multi-month dispensing. However, as a country, one of the things that helped us to identify why we have clients at 3 months, multi-months, and limiting it that to the minister, as a Ministry of Health and as a government, is because what we have within our health facilities and at the central medical stores, that is at KEMSA. Because we know India is still under lockdown and most of the drugs that we have come from that country. So it's going to affect the commodity stock status. And I'll be showing that in the next slides of how we are doing. And so that one is really what was made us to make that decision and limit it to that, and requesting as well our healthcare workers at the facilities to adhere to that, so as we can be able to at least safeguard what we have at the stock status we have in the country. These are the guidances that we gave. You know, we noted later that it is not really reaching especially the sub-counties level. It's reaching at the county level. And this time, I think we'll use other more platforms to ensure that the guidance given by the Ministry of Health reaches even up to the level of the health facilities. This is one of the guidances that we gave in regarding to the children to optimize to the right regimens. And as well, you know, what I highlighted before, you know, straw phase of nevirapine phase out among CALHIV, and as well, the clients who were on the first line regimen distribution trends between June 2020. But this data we assessed it to at the 14th of July 2020 in terms of the ones who are DTG based and the other ones who are on nevirapine based. I think I will not highlight more on this, and I'll go to the commodities. Noting that's how we are doing, and I think I like showing this slide because it will be able to let us know how are we doing as a country. So when we say please issue only 3 months multi-month dispensing for the clients and not 4 months and 5 months, so as at least we are waiting the other country where we get the supplies, that we do not utilize everything that we have and don't have stock out. Because one thing we know is we need our clients very suppressed, both children and adults, and as well as adolescent and young persons. And so if we do not have the drugs, then you are predisposing them to the COVID-19, which is really not fair. This is still the months of the commodities we have as a country. So impacts of COVID-19, definitely we have the shortage of APIs and excipients and other materials leading to delayed manufacturing. You know, we have had suspension of international flights, but at least now things are opening up. Lockdown, especially in India, has really affected our stocks in the country, and use of Opinavir in management of COVID-19 in India has led to us having shortages in Opinavir, and as well as in country COVID-19 prevention protocols, you know, in social distancing, we know, working from home and duty rotation. So our main focus right now, especially our focus on the virus suppression, is expansion of DST models to address needs, especially of children. We are strengthening peer approaches, strengthening HIV literacy among caregivers of CALHIV, and as well as optimal ART formulations for CALHIV and adolescent adults living with HIV, and as well review ART guidelines with clear DST guidance. And that is what we are doing right now, reviewing the HTS guidelines as well as ART guidelines as a country. I think this one has already highlighted in terms of what our priorities and lessons learned, and the next step that we want to undertake as a country to ensure that we safeguard our clients who are HIV positive, and as well the ones who are HIV positive but do not know their status, that they're able to access the services that are needed so they can know their status and be able to access the treatment. And as well as, reconsider the programming of, we are requesting the partners of funds to procure more PPEs and HIV self-test kits. So as especially the clients who are working in the comprehensive care clinics and HIV testing services areas, they be protected because they interact with the clients one-to-one, as well utilization of HIV self-test kits. And that's for all from me, and we really appreciate Kenyatta National Hospital for this opportunity, for this, and as well our county governments, the Minister of Health leadership, implementing partners, development partners, to ensuring that we have continuity of health services in HIV prevention, care and treatment, even amidst of the COVID-19 pandemic. Thank you so much, and we hope you keep safe. Back to you, Dr. Kenodia.
Thank you very much, Dr. Ngugi, for that presentation. And it's really, really amazing the amount of work that is actually going on behind the scenes to ensure that we reach to a level where we move the HIV epidemic downwards. There's a question here from Maurice Aluda, and maybe you can touch a bit on that. In terms of TB screening among people who are living with HIV and AIDS, and even the people who are newly diagnosed to have HIV, has it been impacted with the COVID-19, especially with the similarity of symptoms between, some of the symptoms between TB and COVID?
Thank you for your question. Yes, we know definitely because COVID-19 is bringing in respiratory signs and symptoms. Yes, it has been affected, negatively definitely affected, and I think the TB program, they are working on the communication to ensure that we do not miss a client's mother who has COVID-19 to a client who is having TB, and I think that communication will be released very soon.
Thank you very much for your answer. Maybe a question from my end in terms of like your presentation. So long term, what do you see happening? Like I've seen with the graphs, and there's not a lot of change in terms of the numbers of testing and treatment, but long term, do you see us having the effects of COVID-19 in HIV programs in terms of testing and viral suppression, or do you see us going back to normal the way we were, or just increasing? And then would the extended dispensing be enabled even after, or once the pandemic has been declared not existent?
Okay, thank you for your question. I think one thing we have to note is we are still learning. And I think one of the areas that I mentioned is at the beginning of the year, for example, mother-to-child transmission, we were around 10.8. However, with COVID-19, because we know most of the clients are not really accessing services, most of them, and it is definitely going to affect. For example, I think what I am projecting right now is in terms of identification. Yes, in testing, we know, first of all, our clients are not really, even though we have around, for example, in July, we had around 11,000. You can note we have had 8,000 gap. And now this is what we have been able to note in terms of the DHIS. But we note still that our clients, we have many positives who are not being identified. That is one. Even though we have put in measures, for example, use of HIV self-test kits, and I know most of it's still, clients or the public are still learning about how to utilize HIV self-test kits. I know the public sector is free, but still we do not have enough of HIV self-test kits, but we are procuring more, but the need is high. And within the private sector is around 500 Kenya shillings. So testing, yes, I know it's going to be affected, and you can note from what we have noted from between January and to July right now. Yes, in still viral suppression, is we know we'll have a dip or clients not who have severely suppressed. And that is why we are utilizing the many platforms as possible. For example, we are utilizing like HIV testing, refresher courses. And yesterday we were training almost 1,000 HTS providers all over the country virtually, utilizing the other platforms. So as we ensure that we have continuity of health services, because what we have noted now is COVID is here to stay, and it's our new normal, and you have to adjust and see how do we ensure that we align to it and be able to continue issuing the services. Yes, we'll be affected, but are putting in measures. But by the end of around December, when we have good report for the last 8 months, yes, we'll be able to report where we are. But we hope that we'll not have a bit of a difference in the services that we are offering. Thank you.
Thank you very much, Dr. Catherine Ngugi. A follow-up question from Maurice Aluda. I know we've discussed community strategies that have been employed, especially for people who inject drugs and access to their HIV care. But which community strategies have been put up in general for people who are living with AIDS, not necessarily the people who inject drugs? And then has this also been put up for TB, since it remains a major cause of mortality?
Okay, thank you for the question again, Maurice. And I think I think I mentioned about something called differentiated service delivery models. Differentiated service delivery models is like tailoring the services to the need of the certain populations or even certain specific geographical areas. And to limit our clients to having to come and crowd within the health facilities in the country, what we did I have mentioned or highlighted into it is the guidance that we give is that we utilize a model called fast track model. Fast track means that when a client comes to the health facility, they'll just go directly to the pharmacy, pick their drugs and go. So a minimum of 5 to 15 minutes, they'll be in that facility. That is one type of a model. A second type of model is the one called community AR2 groups. What happens is we'll have around, for example, 15 clients who are HIV positive, appoint their own team leader, who then will go to the facility, pick the drugs on behalf of the 12, and then go and distribute the drugs within the community. So these 12 clients, they do not have to come to the health facility to pick the drugs. That's a differentiated model. And then the other one is, for example, in clinic appointments, that the hospital will be able to talk to the clients and inform that come on this certain date to come for the facilities. We know, yes, in the public sector, it's not really 100% being utilized, but that is one another model that it's being used in some of the health facilities. Back to you, Nancy.
Thank you very much. I'll take a question from Joseph Otora, who says TLD is known to do very well in terms of viral suppression, but in terms of optimization, what cases are there of EMTC mothers who are on TLE regimen since regimen interruptions may result in transient high viral loads?
Thank you. And I think I want to, is one of the slides that I showed in terms of performance of the TLE and TLD, in terms of how the clients virally suppress, and this one is I know because of in 2018, we had several circulars, even though the WHO issued guidance that it is safe to have DTG, but then from Botswana, we had cautions of clients who had, adverse effects or side effects of out-utilization of TLD, is that pregnant and breastfeeding women, especially past the first trimester, it's safe for them to take up the TLD. Yes, we note there's that issue of viral suppression. For example, one can argue a female who is on a TLE are at 92% of viral suppression, and as well in TLD 96%, which is still better at 90%. But TLD, we know in the suppression is a bit faster and a bit better than TLE. And as well, we know the other side effects, especially of valence-based drugs. So for us, as a Ministry of Health, I think information is power. And when clients are offered with the right information regarding to TLE and TLD, then they are able to make the right decision that fits up to them and to ensure that they are comfortable to take the drug, and as well retention and adherence of the drugs. So I think comparing these two, both TLE and TLD in terms of suppression, it is not really hard, but WHO recommendation is let's have clients on TLD who are either breastfeeding and the ones who are beyond first trimester. But for men, we know we are having a hitch, but as well as a country and as well within sub-Saharan Africa, we are still noting and having repository of the several adverse effects that are being noted among the clients who are taking TLE and TLD. And our request is, through these various platforms that we have, that if any client notes that they have a certain side effects, then that they're able to report within the health facilities as we have. Even though I know the PPB, Pharmacy and Poisons Board, they're having a platform where clients can be able to report the several side effects that they may be noting out of taking of the drugs. And we know we have just introduced these drugs, maybe 1 year old, but it is good as well as a country, we note what are the side effects that are coming out from the clients taking the drugs. Back to you, Nancy.
Thank you very much for that answer. I'll take a question from Kareni in terms of the donor funding. So with COVID-19, and I know there's been a lot of discussion as to also, even prior to COVID-19, discussion was on how the donor funding will reduce. So has there been any effect on service delivery or implementation of donor withdrawal during this COVID-19 pandemic?
Thank you, Karemi, for your question. I think I want to maybe bring a bit of light on, what is on the media and what we have in the ministry. And I think one of the things is there's no donor that has withdrawn the funding. It's just that, measures have to be taken, and I think we have in controls within the ministry and within the various organizations that have donor funds that they're either managing. For example, if it is, and I'll speak within my context of HIV and STI, that the donors who are supporting us to, to procure maybe PPEs or HIV drugs or HIV test kits, we still have them supporting us. And within, for example, PEPFAR agencies, through CDC, DOD, or USAID or Peace Corps, they usually fund directly to the implementing partners who work closely with the counties. Those services are still happening, and they have been able, for example, to support in procuring of the COVID-19 either consumables or the PPEs that are being utilized. So we have not seen any, and I think our ministry, our cabinet secretary and our principal secretary, Madam Muchache, and the Honorable Mutahi, is that they are on top of the discussions with the donors, as they mentioned in the various forums, to ensure that we as a country are able to safeguard and ensure that we have services continuing for our clients. Thank you.
Thank you very much. I'll ask a question from Judy Mashuka, even as I request maybe Prof. Nduati and Dr. Maritim to maybe make comments after the question if they have any. So Judy is asking about the messaging for HIV services. Has that changed with the COVID-19 pandemic, such that it's allowed our patients or our clients to seek services despite the messaging of staying at home? So what difference have we made in our messaging?
Thank you for the question, Judy. We have a Ushauri platform, which before COVID-19, we had around 100 facilities utilizing it. But now with the COVID-19 through Global Fund and as well as through mHealth, and as well utilizing the other donors through CDC, is we have been able to increase to almost 400 health facilities. Remember, we have around 1.3 million clients who are on treatment. So when you talk of 400 health facilities, we're talking around almost 400,000 clients who are on within those facilities, utilizing that platform for messaging. However, we are reworking in terms of how to empower and facilitate the counties to ensure that they undertake HIV and COVID-19 discussions. We know now at least we have a bit of information that they can be able to, for example, in IPC, and as well to our clients, how to better take care of themselves so as they do not predispose themselves to COVID-19, and as well the ones who are HIV positive and acquire a COVID-19, what measures to undertake. But especially more insisting and requesting our clients to ensure that they religiously take their treatment so as they can virus suppress and ensure that their immunity is better off, other than the immunity being a bit lower. So we are reworking that one, and more we want the work to happen, not at the national level, but at the communities. So we are reworking how to facilitate the communities, especially on messaging, which we know we have taken a bit of time, but we have noted now because, we cannot do flyers, but we are using the virtual platforms. As I mentioned, like yesterday, what we have, every week we have trainings, especially on sensitization, either in care and treatment, in strategic information, and as well as in prevention, to ensure we keep each other on top of what is happening within the globally and as well as within the country, and what our data is informing us on how we are performing in terms of the counties. For example, when we note that a certain few counties are not doing well in terms of testing or clients who have dropped off because of treatment, then we are able to reach out into the, CASCOs, the County AIDS and STI Control Coordinators, and as well as, the medical rep people, to ensure that, ask them, is there a challenge, so as we can facilitate them to ensure that they have continuity of the health of the services within the counties. So those are some of the measures that we are undertaking, but we want to do more, especially now when things have opened up, ensure that the work can continue within the health facilities in the country. Thank you.
Thank you very much. I'd like to give a chance to Professor Ruth Nduati. I can see you, and Dr. Maritim, maybe if you have comments before we proceed to the next batch of question and answers.
Good afternoon. Thank you very much. Dr. Kate, you made an excellent presentation of the status of our HIV program. I think I'll just reiterate that what Dr. Kate has said is going on. the health services are available. Individuals are being encouraged to access services. I think the fear of acquisition of COVID is probably what's keeping people away. The gap in testing, and I think and a significant part of that gap in testing is among antenatal mothers, is worrying. In that we anticipate that we will have increased number of children who are who acquire HIV because of that gap, and so the need for us to use all platforms. So not only when we have a discussion like this around HIV, but when we are even in other forums, in other situations, to keep reminding people that these services need to go on, and that it is in our interest to actually access the services, as opposed to not accessing and then we have a gap in what happens. I think we also need to face the reality that donor funding around HIV will decline. The writing has been on the wall for a while now, and so we need to invest as a nation. But I think even more important is investing in prevention, so that we don't continue to increase the number of people living with HIV, but I'd rather, sustain them, make sure that they get the drugs as they require, but not to increase the numbers. I want to ask Dr. Kate, and maybe this is a good place to discuss, is this challenge of testing in the ANC, the standoff between the nurses and the lab technologists, and which is partly pushing us towards that use of self-testing. What progress do we make, and what platforms do we have for trying to address that problem, because that also is part of the contributor to the gap in testing. There's no HIV service unless you identify that somebody is infected, so that you're actually able to provide the right service. And because I won't ask any other questions, I want to make the observation that COVID, the situation of the COVID infection has also opened up fantastic opportunities. I don't think before Dr. Kate would have talked of giving a 1-hour session or seminar and reaching 1,000 health workers. So I think the opportunity is phenomenal, and it has the potential for improving the quality of services and standardizing the services across the nation. Thank you.
Good afternoon, everybody. This is Dr. Maritim. I'll just make a few comments. So thank you, Dr. Kate, for an excellent presentation. And we are very reassured that despite COVID-19, we have had the program has put in place measures to secure patients and be able to access their treatment. So that is really very commendable, that despite the pandemic, services have been disrupted, but not catastrophically. So that is really a good point. And just to emphasize, saying, I think the COVID-19 has been presented as opportunities where
Hi, Dr. Maritim. You're breaking up.
Because we have shifted the care from being healthcare provider centered to making it more patient centered, because the patients are taking charge of their treatment and they're being entrusted to take treatments for longer duration of months, and this seems to be working. So I think one of the things that for us was concerning is at the onset of the epidemic, even as we made the national guidelines for COVID-19, we were scared that patients who have comorbidities would have an adverse outcomes. And in that list, we had HIV positive patients being included there because we did not know much. And current data seems to suggest that HIV disease does not really increase the risk significantly. compared to other comorbidities, for example, like diabetes, obesity, and advanced age. So that is really fairly reassuring. And we know that as you collect more data, this will become more clearer going ahead. I think one of the other things I wanted to highlight is that even as we look at what the HIV program has really provided to the response, is that there's been leveraging of resources where the testing platforms that were developed for HIV and widespread all over the country are the ones that were really used for testing for COVID, because those are the PCR platforms like the Roche Cobas platform that have actually provided the infrastructure for testing of patients. And this is really commendable, but it has provided a challenge whereby maybe the HIV program has felt the impact because COVID diagnosis maybe has impacted because now of competing priority for testing, and therefore viral load for HIV may have been slightly adversely affected because of sharing the same platform. But from the data that has been presented, maybe what the national program did, the HIV program did, was to develop that list of prioritization of who needs to be prioritized for the viral load testing among the patients who are at increased risk. But this is really commendable, sharing this data on this platform and showing us that you have done well despite the adversity. And we haven't done, COVID has not really gone away, but we look to a brighter future when maybe COVID will be well controlled and we can be on track to achieve the targets that have been set. Thank you very much.
Thank you, Professor Ndwati, and thank you, Dr. Martin. Always appreciate your guidances and availability to ensure that as the experts in HIV and STI world that you're always available to guide us. We really appreciate both of you. Let me answer a few questions as asked by my seniors, is from Professor Ndwati. One is in regarding to testing. You know, when HIV came, you know, we had the first diagnosis sometime 30 years back. You know, it was fire. So that means that everyone came with their bucket to put out the fire. So what happened is we task shifted the testing, because when we realized, if you can remember during that time, we had clients being issued with a request to go to the laboratory for P24 markers. And we had most of our clients, you know, committing suicide, you know, others being in denial, I don't think I'm positive, and the likes. And then there was introduction of HIV testing services whereby there is counseling incorporated into it, whereby your clients would be able to sit down with the counselor, you know, you are taken through pre-counseling and then you are tested, and then post-test counseling, whereby you can be able to see that that is the click have been done, that's my blood, if it turns 2 lines, then you can be able to own up the, you know, the results. Now, over time is, and I think was a gap, is we never put in a policy, you know, putting in that this specific cadre. And remember, we did not have HTS, HIV testing services providers within our scheme of service. It's the governments of Kenya in terms of public service, or even within the counties. So then it was either the clients who are living with HIV or community, you know, health workers. So even in terms of the minimum wage for them to be paid is usually at a prerogative of the implementing partners on the ground. That some counties, you'll know that they're paying 15,000, others are 20,000. But remember that they multitask in several areas, that they support the counties as well as the government to ensure that they implement, you know, and ensure that we have continuity of services of our clients. Apart from having to test the clients, and even nowadays, you know, even holding that client hand and linking them to the comprehensive care clinics to ensure that they are, you know, they're taken up by either the clinical officer or the doctor, that it can be explained for about the drugs, and then even up to retention and adherence within the communities. Now, over time, we had, you know, Ministry of Health, there was an issue that was raised up in court that we are utilizing cadres that are not recognized. And so as a Ministry of Health, I know through the Director General's office and through Dr. Onyancha's office, for the last couple of months, we have been having engagements with the Kenya Medical Laboratory Technicians Board, and as well as several associations. So as we can see, you know, the impasse that we are having, how do we deal with it? There are several conditions that have been put in, and what I can assure you is we are in great discussions within the several organizations and several stakeholders, because we know for us to, the gains that we have made so far, it starts from identifying that client. So if we miss out all, for lack of a better word, mess up with by the time the client is informed that they are positive, then they will not be able to adhere to the treatment and even have disclosure, or even, for example, a mother who is pregnant be able to take up the medication. Well, that means that the first 90 is very, very important. As you can see, that's one of the areas we are having gaps. So, and we know that it is important. And for example, we really appreciate PEPFAR, because almost 30,000 of the clients, 30,000 of the HIV, HTS providers we have in the country are hired by PEPFAR through various agencies and the implementing partners. And through UHC, as we are hiring community health workers and community health volunteers to undertake that, and the package of the community health training curriculum undertakes as well HIV and AIDS and even TB and malaria, to ensure those workers can be able to undertake those tests. So yes, we're in discussions, and we know that it has really affected, especially antenatal and postnatal testing. But we hope within the next 2-3 months that we'll be able to solve that issue once and for all. And already our cabinet secretary and the principal secretary, they are aware of it and are addressing it, even with the DG. Second question is, we know, yes, and it has been, the writing has been on the wall over the time that donors are going to reduce the funding. For example, I think I want to bring to attention that yes, government of Kenya is really taking up the position of ensuring that offers the services that are required for the people living HIV. And let me give several examples. Number one is, last year, we know through PEPFAR, they used to buy for us HIV test kits amounting to almost 12 million. And that one has been taken up by the government to all HIV test kits and dual kits of our mothers are going to be bought by the government of Kenya. And we thank our president and our cabinet secretary and the principal secretary for ensuring that one happens. Last year as well, and I know you see right now we are having issues, Septrin, which used to be bought wholly by the donors. And last year, in around September, October, the Ministry of Health was able to allocate 1.2 Kenya shillings billions, 1.2 billion Kenya shillings to buy Septrin. Yes, we know, and as well with issues with procurement, it has to undergo the procurement process, which was started in January. But I know, and because of the amount, because we're talking of several millions of packs, that the ministry, the APIs which comes from China and India has affected the raw materials, have affected production of it locally. And we are hoping that we can be able to have the drugs very soon. But I know this COVID-19 and the lockdown has really affected that. Thirdly is issues to do with HIV self-test kits that the government is undertaking to buying. And fourthly is we know that in terms of antiretroviral drugs, over the years, we have had in terms of 100% that 50% were being bought by the donors and 50% either by Global Fund or the government of Kenya. But the commitment from Treasury in the letter, and commitment has already come in terms of even a letter, is that in the 2020-2021 that we will have almost 3.9 billion, and then the next year 4.1 billion and 4.3 billion. So almost 40% of our ARVs will be bought entirely by the government. And looking over the years, and that's a commitment the cabinet secretary and the the chair of the COG, His Excellency Oparanya, made the commitment to the donors that they will take the buying of the HIV commodities over the years, so that by the time we are reaching 2030 or 2028, that 100% HIV commodities will be bought by the government of Kenya, either at the county level or at the national level. Coming to the question of Dr. Martin, and thank you. Yes, we know that some of the machines that are being utilized are from the HIV infrastructure in terms of viral load and early infant diagnosis. And we know, yes, Losh and Abbott and as well COBAS, one of the negotiations we had with the team that is working in COVID-19 is to ensure that we don't disrupt the services of the people living HIV, either in viral load or EID. And so thus we have certain machines that have been put aside to ensure that the services continue, but as well some of the laboratories within the country are entirely handling the viral load and EID, so that we do not have disruption of the services of our clients, especially the newly diagnosed or the clients who are on treatment, so as we can be able to monitor how they are doing. Yeah. And that, I hope I've answered all the questions. And thank you again, Professor Ndwati and Dr. Martin. Always appreciate your support.
Thank you very much, Dr. Ngugi, for answering the questions, and Professor Ndwati and Dr. Martin for that input. We'll proceed to the question and answer session. Maybe a few questions. There's a question here from an anonymous attendee in terms of what is NASCOP doing during this era where during the lockdown people were displaced in various towns and in various cities, and people could not access maybe areas that they were used to taking their HIV care. So has this disrupted HIV care, and what were you doing to overcome such barriers, especially during the lockdown?
Thank you, Nancy, for that question. We know in the month of March and April and May, especially when we had total lockdown of certain cities, and you know, because of stigma and discrimination, we had our clients who are going to access services being affected. Let me give an example. In Thika, we had, you know, the barrier was put in around around Brupost, just there above. And we had clients who were accessing the services either through Muranga or Muslim Muranga, and as well through Keno area. We had a discussion with the county AIDS and state control coordinators. They were able to be given, some were able to be given the letters to go. But as well, remember, we have many clients who are living with HIV, but they have not been able to, you know, to disclose. And that's why, even though they come maybe from Thika, they will go to another town to pick up their drugs because of that issue of stigma and discrimination. And some counties were affected. And what happened is, and thank you so much to the communities living with HIV, were able to reach out to the county aid coordinators, either get letters or even be able to be facilitated to pick the drugs from another facility and pick. But we had some losses here and there. And we, at that time as well, we noted that some clients, they went for some days without taking the treatment because of that issue of disclosure. But right now it has been sorted out. But during that time, yes, we noted there was a bit of an issue, especially through the counties which had lockdowns.
Thank you very much for that. A lot of the people are actually, like for Timothy Moshiri saying, very good presentation, highly informative. And a lot of the people are even asking for presentations, meaning it's been a really, really good presentation. What would be your parting shots, Dr. Catherine Ngugi, concerning the impact of COVID-19 on HIV programs, or a message you'd like to give to the healthcare workers throughout the county since they're logged in? Which message would you like to pass across?
Thank you, Nancy. I think first of all, it's to appreciate the work that has been done greatly by the county and the healthcare workers in general, because we'll not be having the data that we have if it wasn't for the healthcare workers, for their commitments to ensure, despite the COVID-19, that the services continue. And I know at the beginning we had issues, especially to do with the PPEs, but as well, even during that time, we could be able to utilize what we had. Secondly, is to thank as well the implementing partners through the various donor agencies we have in the country for ensuring that we have continuity of services, and they were able to reprogram some of their funds that they had envisaged to use it in other areas to ensure that they cover the clients that we had. So the people living with HIV, we request that continue taking the drugs that you have, and as well ensure that you keep your clinic appointments, and as well know that we have platforms that can be utilized either for messaging or as well if you want to see a healthcare worker. To the general public I think is to see how you can access the guidance that was issued on 24th of August, which highlights in HIV testing and case detection, identification. Secondly, in ART, continuity of care and treatment, especially utilization of differentiated service delivery, and especially the PMTCT and the newly diagnosed clients and people who are living with HIV who have not really virally suppressed, to ensure that they can access that. And on the other areas, the active transition of clients to TLD, and the children who really need to be put on the right optimal ARV-based regimens based on their weight. And as well to know that despite utilization of the infrastructure and to the of HIV to COVID-19, that laboratory services is continuing, especially on the viral load and the EID. Now, in regarding to the area that I mentioned about the clients who have been lost, who have missed appointments, for example, the 30 days. In that guidance, we have given updated strategic information guidance within the COVID-19 times and beyond on accounting for clients on transit who pick refills from different facilities, and as well as accounting for transfer out clients and the treatment numbers for facilities closed due to COVID-19. We have given a very comprehensive guidance. And as well, thanking the Minister of Health leadership, from our cabinet secretary to the principal secretary, as well as the director general, for the guidance and the support they continue issuing to NASCOP. And to the NASCOP team, from prevention team, care and treatment team, and the city team, thank you so much, because there's a lot happening behind the scenes. And the platforms that we have, we ask that when we request you to log in, kindly be able to log in and be able to learn more from us. And the areas that you feel we need to update the public outside there, we are always available to ensure that the services continue. Thank you so much, and really appreciate. And finally, is to the Kenya KNH and Research Unit, Dr. Kinodia and the team, and Nancy as well. Thank you so much for this platform that you have offered us to be able to tell the public where we are and the areas that we are having gaps and challenges, and to ensure that we have continuity of health services in HIV prevention, care and treatment, even within the context of COVID-19. And requesting everyone, please keep safe and ensure that observe the COVID-19 guidelines that are given over and over from the Ministry of Health and globally. Thank you very much, and have a good evening, everyone.
Thank you very much, Dr. Catherine Goki. Indeed, that has been a really good presentation and an eye-opener. We hope to give this platform to many people who would like to give us information that needs to be passed across the country. Thank you to our attendees for attending and staying on up until the end. We really, really appreciate that. As usual, tomorrow we will have our experiences in managing COVID-19. And then every Wednesday, kindly mark your calendars. Every Wednesday from 2 to 3:30, we're still continuing with our series on the medical legal issues in health. So how do you stay in practice and out of court? Even as you're attending the webinars and the Q&A, kindly also give us suggestions on what you'd like to hear. Would like to also respond to the needs that are there and what people want to listen to. Finally, thank you to Dr. Kinuthia for providing this platform, and Mr. Mwenda for the work you're doing in the background. Thank you all. Have a nice afternoon.
Thank you.
Thank you.
Okay, thank you and bye-bye.